again, it's an honor to be here. I'm going to talk about revisional cases, which is always always an interesting topic. I don't know if people have a patient like this. I have several patients like this, but y'all probably can relate to a patient like this. I know Santi probably has had a patient like this before. So this is a patient that in 1998, this was before I went into practice. I was still in the residency at that time, but she had a vertical banded gastroplasty. She was a 32-year-old female at the time, had a vertical banded gastroplasty. Her BMI went to 45 down to 32. She regained her weight. She came in and her BMI of 44. I was in practice. My partner converted her vertical banded gastroplasty to a gastric bypass laparoscopically. Her BMI went from 44 to 27. She then regained back to a BMI of 43. We reevaluated her, and we were early in our experience, and we thought maybe we made the pouch a little too big, and the limbs were not quite long, so we redid the bypass, and she actually responded fairly well to that, which kind of surprised me now looking back at it. But she had got down to a BMI of 33, and she regained to a BMI of 47. So then she came and saw me, and my partner had already left, and I said, okay, we're going to get after this. So I converted her to a biliopancreatic diversion, gave her a long biliopancreatic limb, and she got down to a BMI of 22. That worked well for about a year to 2 years, and then she regained a little bit to a BMI of 26. So she was still, her BMI was mostly normal, but she had malnutrition with leg edema, some vitamin deficiencies. I put a distal gastrostomy in her for nutrition because I just basically lengthened the biliopancreatic limb, and I didn't take out her stomach. I didn't do a sleeve, so it was not a duodenal switch. But anyway, I put a distal gastrostomy in her, and she improved a little bit, but never really perked back up. And so finally I decided to reverse her back to a standard bypass, which I did in 2014. So Pablo, what do you think what's her BMI right now? It's about 45, yeah. Her BMI is 45. So my disclosure by all of this when you do revisions is that we operate on a chronic disease, and you know, in my opinion, I will not always win, but I will keep trying. You could argue that I should have stopped, and I would certainly think that there was a time in retrospect that I would stop. But I do have the philosophy that if they're willing to work with me, I will do my best to work with them. And as a result of those types of patients, we've tried to incorporate every aspect of care we can. You know, lots of medical therapy, endoluminal procedures, but surgery is part of it, and revisional surgery is part of it. Revisional patients are not all the same. You know, you have these patients that come in with just pure structural issues and they don't have weight issues, such as a lady with a biliopancreatic diversion that now has severe malnutrition. Weight's not her issue, she has other issues. Or a band that's a badly slipped, or a bypass patient with a marginal ulcer. They can have normal weights, but they have to have something else done, and those are one population of patients that we have to deal with. And then there's the opposite patient. They really don't have any structural issues that you can find. You look for them, but they just have weight issues. And some of them have inadequate weight loss, or whether it's mild or severe. Some of them have mild or severe weight regain. And the types of those, whether they regain weight or they haven't lost enough weight, are different types of problems as well. So you also have to manage their expectation, because some patients have lost exactly what you'd expect them to lose from the operation, and they're still not satisfied and they want something else. And then of course you have the patients that fit in the middle. They have both. They have structural issues like a gastric fistula, and they regain weight because of that, or a band that you just can't adjust and they regain weight because they can't eat properly, or their upper sleeve is dilated up, or they have an abnormally long common channel in their duodenal switch, or something like that. So those patients have both weight issues and structural issues that need to be addressed. So revisional patients are complicated. They're not complicated just in the operating room. They're complicated before you even get them to the operating room. And we spend a lot of time working on how we're going to operate on these patients before we even take them to the operating room, and then technically do the operation. And so the one thing I think that we do that I really feel like is a good idea, if you have a group to do it, is get everyone together in the same room and talk about these patients as a group. So we have a revisional board. It's like a tumor board. And so these patients get presented in a group, and we say, this is our idea. We get the psychologist to agree that this makes sense. We get the dietitians to agree that this makes sense, that they're properly educated to go forward to try to prevent operating on a patient five times. We don't always succeed, but that's the plan. As it relates to these operations, obviously lap band's fallen out of favor quite a bit. It's still out there, but not too popular. Sleeve gastrectomy has become very popular. Gastric bypass is always has been around, and duodenal switch, more people are talking about it, especially in the single anastomosis forms. But if you look at the trends, and we were just looking at this a minute ago, but this is in a graphical form, you can see how band came on and it dove into bypass utilization and then faded away, and then sleeve came on, and sleeves come on like a crazy. So it's a very, very popular operation, and it makes us ask the questions, how do we choose an intervention? And oftentimes the patients get to decide that, or the surgeons decide that. But I see in the United States that sometimes it just seems to make a lot of sense to do one operation over and over and over again because it's a good business model, and we end up talking ourselves out of being as comprehensive as we should be. And that really kind of plays into how we have these one operations that tend to become the main operation. And I would argue maybe we don't need to have one main operation. Maybe we need to have a lot of operations available. This is a trend of procedures as you go way back to the beginning of bariatric surgery. So, of course, if you looked at this from a pure number standpoint, it wouldn't look like this, because obviously there's been a massive growth in bariatric surgery since the 1960s to now. But this is a percentage of those total cases. So looking at that, it started with jejunal bypass, and then gastric bypass came on when Mason did it, and then that faded away as we realized jejunal bypass had some real risks: liver failure, blind loop syndrome, bacterial overgrowth. It faded away, and then bypass came back up and was the big thing. And then vertical banded gastroplasty came on. Mason himself, who developed the bypass, then developed the VBG, and said, this is better than a bypass. This is the one procedure we are going to do. And of course, it faded away and bypass came back along. And then we're back to the area where I just showed you, where lap band came on and then faded away, and now sleeves come on. And I put that 2020, that's just totally my projection. Are we going to have a contraction in sleeves because we're over-sleeving people? I think it's something that we need to be thinking about, because there are significant issues with sleeves, reflux being one of them. People are starting to talk about Barrett's, and I know that's going to be a big issue. So we're going to be doing a lot of revisions, is my point. We're going to be revising sleeves. You know, the nice thing about, as we know revisions are going up, the nice thing about sleeves is that they are revisable, and there's lots of revisable options. And we're going to have discussions, obviously, about, single anastomosis, biliopancreatic diversion. There's things out there, they're not popular in the United States yet, and not popular everywhere. But in Brazil, obviously, iliointerposition has been around, both the jejunal form and the duodenal form. That's popular in Turkey and India as well, has been growing up. Sergio Santoro out of Brazil, he talks about iliobipartition. And then, of course, managing bypasses. We'll still have bypasses, ways to do bypasses, redo the bypass. People are talking again about banding bypasses again. We'll see where that goes. And then biliopancreatic limb lengthening. So there are a lot of revisional options out there. As you look at the history of robotics, I'm going to switch tracks just a little bit to talk about robotics and bariatrics. The history's actually been around. It's about a 20-year history now. Banding, bypass, sleeve gastrectomy, biliopancreatic diversion, and of course a whole bunch of revisions. I think previously it was presented a lot of data about how bypass works with the robot, whether it's a good thing or not. I'll just show one study that doesn't ever get shown because it was published in an obscure journal called the Journal of Robotic Surgery. It was the one study that convinced me to keep doing it. It was when I was first starting to do this and developing a technique. I was working with Santi's, well, he was his fellow at one time, and then became his partner, Robert Berger. And so we started working on some techniques together, and then I started doing it. And basically I did a comparative trial between purely laparoscopic hand-sewn gastrojejunostomy with robotic hand-sewn gastrojejunostomy. Everything else was done laparoscopically. That's all we were really looking at, just the anastomosis of the stomach to the intestine. And the demographics, this was about 5 years of work. and we compared it with 3 surgeons doing this, and the demographics showed no difference in the types of patients we were doing. Even back then, though, we were doing revisions, a lot of revisions, 18 and 15% revisions in this population. The complication rate was no different between the two groups, with the exception of one thing: we had lower leaks when we did it robotically. So the leak rate was lower. So it convinced me to keep doing what we were doing. I don't think it convinced anyone else at the time, but it convinced me, so I kept doing it. Of the leaks that were in the laparoscopic side, that leak rate was 1.7%, which was back then in 2007, 2006, that was not a bad leak rate for a gastric bypass. That's not probably an acceptable leak rate today, but it wasn't a bad leak rate back then. 4 of those leaks were in revisional patients, but nonetheless, we had the same percentage statistically of revisional patients on the robotic side, and we didn't have any leaks. So we continued to collect data, we taught other people, we worked with other people, we got large series out there that showed it was safe. This is a study that shows, you know, five leaks or abscesses in 1,700 patients. So it's a very safe way to do a bypass, and that's how we do it today. We do basically, and this is what you'll see when we go to the operating room, an anti-colic, anti-gastric. We do a looped gastrojejunostomy and then divide it, just as was shown earlier this morning, and then do the jejunostomy. I said earlier that I'm a fan of hand sewing. I hand sewn the gastrojejunal anastomosis. I think it has a very low bleed rate. I think it has a very low leak rate. It will bleed, as you can see from this video, while you're doing it, but it shouldn't bleed post-operatively. And if you do it well, there's really no reason you should have a complication from it. If you have a complication from it, you probably messed up, and you need to look at that yourself. The staplers that are out there for robotics are obviously changing now, and this is the new 60 millimeter robotic stapler that has all the complementary loads to do a gastric bypass, and so those are starting to come out in the United States, and I'm sure they'll be coming out there around the world slowly. So it has that 60 degree of articulation. It has a black load, which you really need. It has 6 rows on all these staples. It has algorithms that measure tissue thickness and pressure. So, and this isn't going to play, but what it basically does will pause for compression, as we saw here. And that results in better staple line formation, at least in the lab. So we'll see how that works clinically. There are some challenges with this stapler right now with buttress, and I do use buttress quite a bit, in that it changes the algorithm a little bit. So they're doing some algorithm changes because there are times that it will not complete a fire when actually it probably should complete a fire, but the buttress is on there, and that creates a different level of measurement for them. So they're working on that. Also, because of robotics, I use internal liver retractors a lot, so I'll try to show that as an example in the operating room. But as it relates to revisions, we do all kinds of revisions, every band revision, every sleeve revision you can think of, every bypass revision you can think of. We've pretty much done them, and this is where I think the power of the robot, as was talked about earlier, can be significant. This study was also shown earlier. It basically shows, you know, a 13.2% leak rate and a 2% mortality rate. It is a little old. This is older data. It was published in 2010. 151 revisions by Sammy Somstein and Raul Rosenthal that were bypass revisions. So that's a high leak rate. This study was also shown where we did 100 patients. The majority of these were previous open gastric bariatric surgeries, fixed gastric bands, what we call Melina bands, and vertical banded gastroplasties. A few of them were lap bands, about a third of them were lap bands. And so not a completely comparative group, but at the same time we had 1 leak or abscess. We had 1 abscess in that population that we saw. So significantly lower leak rate. Other people have also seen their leak rates drop dramatically when they started using robotics and revision. Stephen Scott is a surgeon that did a lot of laparoscopy, was a very good laparoscopic surgeon for many, many years, taught a lot of people how to do gastric bypass, and has always done a lot of revisions. And basically, when he incorporated robotics into his practice over these 3 years, his leak rate just started to plummet. And if you compare the data, he had 6% leak rate for laparoscopic revisions and a 0.7% leak rate for robotic revisions. And if you do a lot of revisions, such as Steve or myself, and you have a 6% leak rate, that means you have a leak in the hospital all the time. You're never not managing a leak. And so that's a difficult situation to deal with from a mental standpoint, much less just the physical work of dealing with it. Keith Kim also compared revisional cases versus primary cases, and I think this is an interesting way to look at it. And what he saw, his revisional cases, of course, took longer to do. His length of stay was, of course, longer, but his actual complication rates were not different. He had a very low leak rate, whether they were revision or a primary case. And I thought this was a way of doing it, because what the robot does is it makes the revisional case more like a primary case on the clinical side when you look at the complications. We've done this exact same type of analysis on paraesophageal hernia repairs. So patients who had primary hiatal hernia repair versus a revisional case. They'd already had a hiatal hernia and it was a recurrent case. And what we had was 265 primaries and 60 revisional cases. We saw very similar demographics between the two populations as far as age and body mass index and gender and everything else. But what we saw when we looked at the complication rates was not big differences. Readmission rate was trending slightly higher, but not significantly higher. Recurrence rate was slightly higher by a trend, but not significantly higher. Reoperation rate was basically the same. And then how the patient felt, dysphagia rate was basically the same. Gas bloat was basically the same. Post-op PPI use was also basically the same. So again, use of the robot makes a primary case and a revisional case more similar. So why would I argue that revisional cases have better complication rates with the robot? I think if you ask a lot of people who do a lot of robotic surgery, they would say, first of all, that the stability of the platform, the camera not moving, when you're doing very difficult dissection, that's a valuable thing. Not having something move at all, so your eyes don't have to compensate for jiggle and wiggle of the camera at all, allows you to focus more on the tissue. And so the stability of the entire platform, I think, is very valuable. And when you do that, you see planes better, and you have no one really helping except when you really need help. That allows you to preserve blood supply. I think what it ultimately does is you damage less blood supply robotically than you do laparoscopically in a lot of situations. And one way of graphically putting this is say you have, because we were talking about this earlier, say you have a patient with a primary sleeve, a BMI 42 in a female, you have this line as the case as the case goes forward. There's times where the case gets harder or easier, but if you look at technical difficulty, we all have a line. Our line may be different from each surgeon to surgeon, but we all have a line where we're like, this is no longer fun. I hate this. I hate this part of the operation. And if you're never above that line, the case feels like a great case. If you live above that line the entire case, you pretty much hate the entire case. But there is a line of tolerance. And a lot of these bariatric operations, primary sleeves, bypasses in lower BMIs with very little intra-abdominal fat, you never get above the line. But then if you have a patient with a BMI of 55 and a male, and you're doing a bypass on them or a sleeve on them, at portions of the case where you may be doing the dissection or the stapling, you get above the line a little bit, and then you go back down and you're okay with the case. Well, revisional cases, sometimes as soon as the case starts, you go above the line and you live above the line the entire time. And if you do it laparoscopically, you're frustrated the entire time. That affects your decision making ultimately. So what robotics does, I think, really, is just drop you below that line more frequently than not. That's kind of the way I view it and see it. So there are ergonomic benefits. I think those are important when you're doing robotic cases, revisional cases, because those cases can be longer. It allows you for complete autonomy. It allows you to manage high BMIs with the same type of approach. And it allows you to manage these hostile abdomens in revisions. And all I really do is try to get enough adhesions taken down where I can get the robot docked, and then I do everything else robotically now. So It has a long history. It's still not mainstream. Still has a way to go, but volumes are starting to increase. Costs are going to come down as we add these other companies in, and there's a lot of companies out there, as we mentioned earlier. And above all, I'd just like to say that, surgery is really about good judgment and not what tool you're using, but how you're using it. Thank you for your time.